Good evening, everyone. It is my pleasure to introduce in 1 second what we're having tonight, and that's the inaugural lecture of Professor Beate Diehl. Beate has been here with us for over 10 years. She originally graduated in medicine in Germany, in Heidelberg, coming from the sort of wine region from Germany. And we might hear more about, the wine that is done there later. But Beate has really made a mark in trying to understand the excitation that the brain causes, not only on researchers, but also what actually happens in terms of improving surgery for people with epilepsy, seeing treatments. But more recently, she has done quite a lot of work in trying to understand what's behind structurally, or if there are some biomarkers for SUDEP, which is a very important issue for people with epilepsy. And it's one of the sort of things that we try to improve or find more about, because that can make a big difference in terms of the life of people with epilepsy. Beate from Germany went to Cleveland. She became world famous in Cleveland, and then she decided to come and do a PhD with John Duncan at Chalfont in Queen Square. And one of the things that I remember of Beate is that we had a sort of lodgings for young researchers, and I think it was called Perry Cottages. And they were very famous for being a mess. And amongst other things in there was even a little shop to, let's put it that way, reassembler or do things to motorbike engines. And the arrival of Beate there was a transformation, because Perry Cottages became a stellar place, all very organized and all working. Even the shop was still working, but now under precise and clear instructions. So Beate left a mark in Chalfont, not only for her research, but also her interactions and getting people to work in a proper way and in a very organized way. So now she's going to tell us why she got here, and I will invite and give the floor to Professor Diehl to tell us, without hesitations, deviations, or repetitions, why you are now a professor.
Lee, thank you very much for your kind introduction. Good question, why am I now professor? I hope the lecture helps at least with some of the things I've done, and thank you very much for taking me down memory lane, because Perry Cottages and the transformation in the cleaning process of Perry Cottages wasn't exactly something that came up when I looked at my photos, but that would have been quite memorable too. That is absolutely true. Okay, so I called this Finding the Focus, or Finding Focus, Improving Outcomes in Epilepsy, a journey through spikes, brain maps, images, and networks. So people ask me often, well, where are you from? And that's sometimes quite a difficult question to answer, particularly if you've been around the world and lived in different places. But still, I think my heart is where I come from, which is in Germany, in the southwest region, in Rheinland-Pfalz, and you can see there's a beautiful wine street. Let me see if this pointer works. That actually goes along here. You see the Rhine here. You see the great proximity of the area. Actually, over here would be already France. You can see that quite well here. That's, I think, where I come from. And there's there are lots of wineries, and there are lots of grapes, and there's a lot of wine being made. There are also some contributions to democracy that had their momentum there. For example, the Hambacher Schloss, the Hambacher Fest, is considered in Germany the cradle of democracy. And you can also see that there are lots of Roman traces, so it was heavily populated by the Romans. And up there you can see actually a coin, and that is one that my grandfather found for me and that I had framed. And you can see here, this is a winery with Roman remnants. Now, I was born in Kandel, which is not far off. You can see that here. And for the first 3 years, I lived in Maximiliansau, in a little village. And just perhaps to go back, when I was born, there was a little bit of commotion, not so much because anybody was unwell, thankfully not, but there was some discussion about what I should be called. And the idea of a girl at that time was it should be an Ute. Ute was a name that is a variant of Oda, and it has to do with medieval German saga, the Nibelungen name. This is the name of the mother of Kriemhild and Gunther, so a very Germanic name. This is what happened. Well, I arrived, and I had these big dark eyes and apparently a big head full of black hair, which subsequently fell off. And I think the bald stage is what you see here, but then it did come back. So there had to be some emergency renaming. And what they came up with is Beate. I don't think they had in mind that I was going to go into English-speaking countries, and everybody would ask me, well, how do you pronounce that? And I've since really started to respond to everything from Beat to Betty to Bird to Beat. But Beate is what it is, and it's actually derived from a Latin root and is blessed or happy. And it conveys a sense of joy, and I do think it did capture the moment here. So overall, quite early on, though, particularly in contrast to my brother, I have to say there were certain features that stood out. The means of transportation and how to get from place A to place B and how quickly that would be achieved. And also how it could be done. You can see here there are plenty of video snippets as I went through all footage that have things like this here. The legs weren't quite working yet, but nothing else really would suit. Other modes of transportation equally weren't suitable. So, I mean, as every good parent, my mother really tried very hard to please me. And you can see, this then worked. So, those were the early days. And this is when I was 3, where we relocated to. This is where my grandparents are from, so my father is from there. And you can see this is a little village. It's actually a small town called Freinsheim. It's in the Rhine Valley. You can see here, this is the Odenwald, and this is the Rhine Valley overall. Over here would be the Pfälzerwald. And this is a medieval ring wall that's still around there. So this is how it has town rights, even though there are only like 200 and only around 2,000 people living there. And you can see, my grandparents were farmers, and there were also quainter moments. And as I grew older, there were certainly also some calmer learning. As you can see, my mother here can direct me a bit more, perhaps. Then, not too far off, came my brother, and you can see this time there was some success with the blonde and blue-eyed theme, but not with the sex. Okay, so Ute still didn't work, and you can see here a rare picture of my parents together, which is, I think, one of the first pictures I ever took, which is why it's really completely out of focus. Anyways, and here, obviously, I had to learn English in school, and then I said I really wanted to go to this small island where they speak English, and these are the very early contacts with this island. I think this was the first family holiday where we came across, and this is actually the way we used to learn English, was via the pen friends, and this was my pen friend. Her name was Kim McPherson, and you can see that we regularly corresponded. And you can see here, when I was here, her dad actually took us out to London, and this was my first meal that was a lot more ethnic than I was used to. So I had amazing experiences aside from learning English. And I finally graduated from the school. I had my Abitur, the baccalaureate, and then I went on to medical school. I went to Heidelberg, but I couldn't quite decide what I wanted to do, even though medical school was something that I thought was quite interesting. I really didn't have anybody medical in my family, and I loved languages, and I loved French. We were close to the French border, so I decided I was going to study both and then choose. Now, I had to have an exemption, which I got to do this, so off I took. And I also had a little bursary or a stipend. So what happened with that is that very early on, I had to always get references that I was working hard and that I was doing my job that I was supposed to do. And this is how I met Professor Menze. I was still a teenager at that stage, and he was a histology professor and teaching us in our very early courses. And he said, oh, well, what do you want to do? And I said, I have no idea. I like many things and I'm really curious. And what do you do in this lab there? And he showed me and he said, well, I just came from Kiel and I don't have a tech. Do you want to be a tech? And I said, why not? Let me go and find out what this is. So I sat down and I prepared C fibers in rats, which are slow conducting nerve fibers that mainly are important for pain. So this is what I started to do, and I actually managed to do it. And I started to really enjoy that new skill that I acquired. And as I went to my very first conference, I came across this man. And some of you may recognize him. So this is where I met Martin Koltzenburg, not professor back then yet, but already right on track. And he seemed to know where he was going, whereas I was not so sure at this point in time. I got my MD thesis, and as you see, it's a very traditional university. It's all in Latin. And as I took a photo of this, a bad photo, as you can see, suddenly my phone came up with some translation of this Latin, and I was really impressed. And I thought, I can't stop myself from showing this. What I got from it is that I obviously exceeded highly with praise. And I thought, well, that's good. Beate Diehl somehow did this. So anyways, I think the Latin version has really to improve. I studied medicine and French, so it was natural that after I'd done my MD thesis and I started to go into the clinical part of medical school, that I would try to combine this. So I spent a year in Montpellier, and here you can see very old medical school, which is beautiful. I had my little studio apartment around the corner. I thoroughly loved my time. I learned a lot of French, and I got really quite good at it. I also did pediatrics. I did cardiology, and I did a stage, what it's called, in neurology. And from then on, I really developed a passion in neurology. So this was an amazing year that told me or showed me already what I really loved about this all. So coming back from that stay, I thought, well, now I've got my wisdom teeth removed, but I've also had this amazing year, and enfin, je me trouve raisonnable. So finally, I've got some reason in my head, but then I thought, well, there's got to be some more things to explore. So I thought, well, how about America? You know, so many of my other friends in medical school went to the US, so I thought I have to try this out. So off I went, and after I just landed in Heidelberg, back again for a couple of weeks, I flew off and I had my first experiences in the US. It was an exciting time. I saw amazing places, and I was exceptionally enthusiastic about all the things that I explored. It was very different. It was a huge contrast to my French experience, I have to say, and I got muddled up between English and French quite a bit, I have to say. My first steps in the US system on the medical side led me to the University of Connecticut in Farmington with the first rotation in endocrinology outpatients. Now, this is a famous photo because I nearly got arrested here by the police. I had my first day. I arrived on a Friday. I had my first day on a Monday. I was still a bit jet lagged, and they put me, just having arrived from France, into an endocrinology clinic to see 2 patients and write letters afterwards. That means dictate. I was completely overwhelmed. I had no idea how to do this. It was turning dark. Everybody else had left, and I was still there. I finally tried to write everything down and then read it off into this dictaphone. By the time I finished, it was super late, and I took my car and I drove off, and suddenly the police turned up behind me. And it turns out that this huge highway of a driveway around the center is a one-way street. So I had gone back the way I came at like 9 p.m. I was distraught. I had to call my best friend from medical school and said, I don't want to do this. I was crying. I couldn't bear it. But then, you know, here's where I stayed. I stayed with a very nice French lady, Hélène, and you can see the bungalow where she stayed. So Google still shows us this location, but we can't drive up the driveway, so you can just see the roof, but that's her house. And it was lovely because she spoke French with me, and that gave me a sense of home. And finally, I calmed down, and I actually really enjoyed my first 3 months there. After I returned to Germany, I had to continue on in medical school with my clinical phase. And now I got curious about clinical research, because now I had done my RATs, and I knew that was quite something. I wasn't so sure whether I wanted to carry forward with more basic science after that. So I explored this, and I landed in a hospital where there was Michael Henneritzi, who is a man who is really quite famous in the stroke research world. And I started learning lots of different things. And I met another Diehl, Rolf Diehl, who is unrelated to me. And we had obviously really hard times together. And we went to a couple of meetings, and we did some research together. And I learned transcranial Doppler, and I explored blood flow oscillations in people with carotid artery stenosis. So I had quite an amazing time, but it also taught me how difficult it is if you publish with someone who happens to have the same name as you. From there, I moved on, and I started my neurology specialist training. I initially started in Mainz, and this was with Kremer and Barbara Tettenborn. And because I had made my first venturing out in the stroke world, I had a first position as a research assistant in assessing clopidogrel in the Capri trial. So I went down the stroke route, but then the chair really was about to retire, and I wasn't quite sure where this was going to go. So I changed, and I continued my training in Münster, where Professor Ringelstein had just come from Aachen, and everything was a fresh slate, and it was easy to do fast your neurology training and move through all the functions and all the things you had to learn. So there, I really explored bringing together what I'd learned so far, transcranial Doppler, to measure blood flow, together with something that I started to develop a passion about, which was epilepsy. And I'll tell you more about this. So I measured spontaneous oscillations in blood flow velocities in the MCA in people with epilepsy, and I found that there were changes in what's called the M waves. So those are spontaneous oscillations in blood flow at 3 to 9 cycles per minute. And now that we're more interested in slow frequencies, also in the EEG, I just wonder what that all tells us and how it stacks up together. It certainly gives us some insights in the autonomic nervous system. It's also always about the people that you meet. And Stefan Stodik here was working in Münster, and he was passionate about epilepsy, and he really excited me about this disease. And I really wanted now to become an epileptologist. I realized that epilepsy affects people of all ages, that it's a very common disease, that lots of people actually could be made better. There's a real treatment gap in epilepsy, and that there's a risk of premature death with epilepsy as well. So I thought this is a really gratifying area to go into. And I absolutely started loving to read EEGs. I had a wonderful time in Münster, meeting lots of fantastic other people in training. Nuclear medicine was fantastic. We did lots of things together. We would explore, for example, new onset focal epilepsies and how many people already had deficits in FDG PET uptake. It's actually quite a significant number of them. And I, again, combined now the two things that I knew. I could do transcranial Dopplers, and I could read some EEG. So I would take people from the ward after they had had their dinner, take them to the lab, sit them down, and combine TCD with EEG. And I would investigate, in particular, generalized spike wave. And here's what we saw. We saw when a burst of generalized spike wave occurs, we see a huge increase in blood flow velocity, which then drops and has an undershoot afterwards. And I really enjoyed seeing this. We also measured respiration and heart rate, and this was a really online way of seeing what is happening. I loved the immediacy of seeing that there were changes that were associated with this. So combining EEG and blood flow also led me to exploring function. So I was curious what would happen if you did photic stimulation, for example, flickering lights. And we measured the posterior cerebral artery, and I saw that there was an increase in blood flow with photic stimulation, but that was less so the case in people with epilepsy. So all this body of work was then recognized in my first award, and you can see here Professor Stephan, and this is in '95 in Berlin. And now comes the next phase. I'm about to finish my neurology training, and I've decided I want to become an epileptologist. So how do I go about this? So close to Münster is actually Bielefeld. So I heard about the Cleveland Clinic Beate meetings. So this is where I went, and I saw how amazing this program was, and it was such an eye-opener to see all these great people. And this is when I thought, well, I really should try to apply to go to the Cleveland Clinic. And you can see here a picture. So this is actually the S building where the epilepsy section is in. So this was my next step. You know, Holly said, why don't you apply? I got my fellowship. He was at the time heading the fellowship program, and Hans Lüders was the chair of neurology. And you can see here the other colleagues that I had at the Cleveland Clinic, and they were just absolutely phenomenal, and they've taught me so much. The logo of the Cleveland Clinic looked like this. When Toby Cosgrove took over, the logo was changed. So the fellowship I spent under this logo, and my early professional years under the other logo. Perhaps just a quick word to Hans Lüders. He's been the person that I think has shaped the way I think about focal epilepsies the most. He has been so kind and generous with his time. He's come and sat with the fellows every Wednesday at 7 a.m. and looked over cases together with us. And they were all unknown, and we had this amazing discussion, and he was so kind and considerate of all our ways of looking at cases and all our ways of perhaps not really approaching the problem from the right angle. He would always take us from where we were. And he obviously has published immensely, and he's left a huge mark in the field. His book of epilepsy surgery, his work on cortical stimulation, by which he's described the basal temporal language area, the negative motor areas, and his immense body of work on semiology and EEG. That all has really shaped me forever. It was a real eye-opener to go there, and I cannot thank him enough to really bring me in a way of thinking that I thought was transformative. I also met Elaine Wiley, who is in her own right a very amazing pediatric epileptologist, and with her I did my first paper at the Cleveland Clinic during my fellowship. We had a young girl, a woman, who had a temporal lobe epilepsy and became seizure-free after temporal lobectomy, and then she had valproate withdrawn as she became seizure-free with the temporal lobectomy, and suddenly she had these big convulsive seizures, and it was all terrible. So she was brought back in the EMU, and we found that she had clearly also traits of a generalized epilepsy of JME. So she was back then placed back on the valproate, and everything was well. I did, from then on, I explored other things. We were looking at FDG PET, so at glucose metabolism, and we were investigating volumetric assessments of the brain and looking at how people with focal epilepsy, with and without cortical dysplasia, would match up against each other. So understanding that was really important. I did a lot of work and was very grateful to Imad's guidance at the time, Imad Najin. And again, my passion of cortical stimulation really dates back to working with Hans. The first paper we did together was looking at cingulate motor representation in humans, which were a few cases. And then later on, we investigated and we found a basal temporal visual language area, which we were very excited about. So I really developed a passion for becoming a surgical epileptologist. And why is that? I know some epidemiologists have some views that perhaps this will be less needed, but I do think it is still true that surgical resection of the epileptogenic focus in carefully selected patients is highly effective, has durable effects, and is cost effective. And if you look at the time, there was also the big trial coming out of temporal lobectomies versus medical treatment by Sam Weber in the New England Journal of Medicine, showing that you have to only treat 2 people with temporal lobectomies to show superiority of this treatment over continued medical treatment. So I thought this is fascinating, and this is really something we need to offer to our patients. So I became more interested in doing it better, understanding better where the seizures are coming from. And in that context, I came across another technique that was pushed and came through the stroke world initially, the diffusion-weighted imaging. And we were looking at whether after seizures, or big seizures, or long seizures, or status, or simple seizures, short seizures, there would be changes in diffusivity that could help us find where the seizures were starting. And I took this actually also to talk to the team here, and I was very, very privileged to be able to spend a year doing a neuroimaging fellowship under John Duncan's guidance, and we continued some of that diffusion research. To be honest, it turned out to be all quite a complicated thing to do. It worked in some people with long seizures, but it wasn't really an earth-shattering moment. It was too complicated, so I don't think this ever made it into clinical practice. I also was really lucky to meet Louis Lemieux at the time and Professor David Fish, who were running the EEG fMRI program at the time. And EEG fMRI, that's an amazing technique. How can you, measuring just this tiny little electrical field that is distorted in a magnet that is 1.5 or 3 Tesla. I thought that was absolutely spectacular. And bringing together the amazing time resolution of EEG with the spatial resolution of MRI, I thought was absolutely fantastic. So I wanted to get involved with this, and I had that opportunity also during this 1 year, and that was an amazing experience. But everything good ends, and I went back, and I was now at the Cleveland Clinic. I was a young staff and faculty, and you can see I was board certified by the American Board of Psychiatry and Neurology. I still am. And you can see here we had wonderful support. So this is my nurse, Diana, and this is us in Little Italy, where I also lived. So we had a really good time, and we were very busy, but I think we really could make a difference to many people. I remained very curious on the research side. So I then thought, well, I've learned about this diffusion. Out came the next iteration of this, the diffusion tensor imaging, where you could reconstruct tracts. So I thought I'd bring together these tracts and learn more how this really ties together with direct electrical cortical stimulation, where we can map where language sits. So I brought together the arcuate fasciculus with the stimulation points from direct electrical cortical stimulation, and we were checking how that would tie together. And I also had the idea of linking together with a wonderful colleague, Robin Bush, in neuropsychology, the memory with a tract that we felt was very important for that, the ansonate fasciculus. And I think as it stands, this is one of the earliest papers that has actually done this and correlated deficits in both visual and verbal memory with diffusion tensor imaging changes, FA changes, and some diffusivity changes. So at that point in time, I did decide I was going to try to convince John whether I could do a PhD, and I was able to actually prospectively do this and bring this together as a non-resident, I think it was called, part-time PhD with the work that I did at the Cleveland Clinic, at the time supported by a grant from the Milken Family Foundation that I had won. And my second supervisor was Hans Lüders. So this was an amazing opportunity. Jean here, my dear friend, was helping from the MRI physics side. After I'd completed that work, and Dr. Lüders moved to university hospitals. There were some changes, and there were also opportunities. So this was the time really to be excited about embracing new opportunities. There were plenty of surgical epileptologists, plenty of people that were exquisite in EEG at the Cleveland Clinic. But I thought maybe if I follow a call to come to London, that might be the way to go. In the meantime, I've never quite left my fellows and my collaborators from that time, and we regularly keep meeting up. But this was now the time where I transitioned to Queen Square. And you can see that I had amazing support and people that were really helping me a lot. It was a very different time, a very different system to me. And there were needs that I thought needed to be met. And John told me, this is a marathon, don't be too impatient, thinking back of probably some traits that I indeed have. And I became very patient, and we ended up opening the video EEG telemetry unit from 5 to 7 days. We introduced ICTL-SPECT here. We set up a fellowship in complex epilepsy. And that all kept me busy probably for about the first 7 years. And you can see here also, just to point out, this is Sheila Smith. She was incredibly supportive as the neurophysiologist, really, that was helping on telemetry. And Tim Wiener, who spent some time with us and initially also helping me, coming from the Cleveland Clinic, going through Germany and spending a few years with us. Supporting the intracranial program, and of course Matthew and Catherine Scott, who was amazing, really supporting us in all the changes that were needed on the video EEG telemetry side, as well as of course John and Leigh. In 2011 to 2016, I then won an HEFCA Department of Health Clinical Senior Lectureship, which allowed me to transition into the university side. Nevertheless, I think the SEEG program that we subsequently introduced remained a very, very complex way of working and required a lot of attention and a lot of things that need to go into it. And I think bringing all the elements together with multimodal integration, the EpiNav under John Duncan has been absolutely instrumental and really, really helpful. Now, speaking of our fellowship, I'm very proud that over these past 9 years, we have had amazing people coming through, spending between 1 and 2 years with us each. And all of them, I think, have gone on and are holding positions and are a great support and are so important to help with building capacity in the UK for epileptologists that are trained in neurophysiology and surgical expertise. You can see obviously on the top with Famida Chowdhury, with Emma Torsillo and Umair Chowdhury. And down here you can see all being here with us. And then you can see Joel Winston, Olivia Poole, and Maria Gentino, all having moved on into great positions. And then something, the most amazing thing, actually, shall I say, happened. Now this is probably not really true to form, because indeed I have less memory about this whole thing than I can admit. And I see a lot in photos. And I have to really say, the sleeplessness is probably what I underestimated most. I couldn't have done having a small child and a baby without the amazing support of my husband, Neil. And you can see both Robert and Neil there in the back. So it was an amazing time. And I have to say, there's one thing I did more, and that is read. So I know Sally Baxendale, who's sitting there, she said she watched videos in that time. Now I started to read a bit more. And at that point in time, this book came out, and I thought, well, maybe that's one that I should read. That seems very important to what I do. It's about patient HM. And some of you may know that this is a man who had an operation that was quite experimental, where both temporal lobes were ablated, coming through a frontal and anterior approach. And that left him really with both hippocampi being gone, not entirely, but almost entirely. And it led to an inability to form new memories, really. So this is quite a profound amnesia. And as I read in this book, you know, the neurosurgeon who was doing this procedure, his name was William Beecher Scoville, and I understood he did undergraduate in Yale and then was at the University of Pennsylvania, and that is him. And I also learned that he actually suffered, unfortunately, he died in a car accident. He loved fast cars, and that is how he died. And it is clear that this one single case has a huge legacy for our understanding of memory. And as I thought back, this really rang a bell, you know, Scoville. And I thought about Hélène, and I put 2 and 2 together, and I found out that I inadvertently stayed at the house of the widow of William Beecher Scoville. So much for coincidence. Now, this place obviously has a lot of history in its own right. The National Hospital for Paralysis and Epilepsy, as it was called at the time, with David Ferrier doing the cortical mapping, Ewlings-Jackson observing what happens during seizures, and Victor Horsley being able to listen and take things forward and trust in what Ewlings-Jackson told him, putting together the first epilepsy surgery. It happened in 1886, and you can see the operating theater right here. So Jackson and Ferrier attended the operation, all without having ever done an MRI or an EEG. It was just observing the seizures that led to such a hypothesis. The power of direct electrical cortical stimulation has continued to fascinate me. You can see it can be done by injecting an electrical current through 2 adjacent electrodes. It can be done through a multiple depth or SEEG approach. We can do mapping, or we can do it on the surface. So one of the big lines of research that I did was bringing cortical stimulation mapping of the brain a little bit more into the limelight, with understanding better how we stimulate, how we should best stimulate, and how we map motor cortex. And in this phase, Stepana Kovac was really instrumental. She did her UCL PhD with Matthew Walker, and in the lab with Dimitri Kuhlmann as well. And she also did some clinical research with us, and this was quite amazing. Now, taking things forward with the mapping, it was critical to meet somebody and to meet a team that was able to underpin this with methods that would help us understand this better. So it's been an amazing experience to work with Parashkev, Nashev, professor at UCL, and Ash Jha. And this is one of the first things we did together on the stimulation side, mapping the medial frontal wall using probabilistic way of looking at the effect of our stimulations. And you can see here, you can draw a map of the brain where positive motor signs emerge when you stimulate, negative motor signs emerge, but also huge areas where nothing emerges, probably because we're not testing, and some bizarre other locations that I will get into a little bit later. Now, recently that's had an upgrade, and that upgrade is to underpin this new way of looking at our stimulation mapping with connectomic mapping. And this is just amazing, because we're not only looking where the effect occurs or where we're stimulating, but we're also looking at the network effect that this might have. Now, I pointed out some of these really odd locations, and these locations do fascinating things. So when you test what people can do continuously, you sometimes come across something like this. You know, first off, you let them tap their fingers. The stimulation comes on when you see this red little sign, and you see nothing really happens. Able to continue with the tapping. But now see what happens when she is meant to, vocalize. Stimulation is on. And she's simply not able to keep the pace. So she isn't able to pause for that little bit in between. She starts almost singing. And working with Parashkev, who is a real expert in the medial-frontal wall, obviously we came up with the hypothesis that in order to perform actions, you also have to be able to know when to do those. So there is an inbuilt need for procrastination. And sometimes I think I exemplify the procrastination more than I should. But in this case, obviously, when you stimulate, this procrastination effect is gone away, and she can't really pause for long enough to keep that rhythm. So fascinating things we sometimes see. So what is this? Beautiful flowers. These are the flowers of the almond tree, the Mandelkern. We had an opportunity looking at cortical stimulation to investigate the amygdala. As you know, obviously, amygdala and fear go hand in hand. It's a really important structure to allow us to flee and to be able to have a clear response that may sometimes save lives when the big boar arrives or the big bear arrives, that we can run away. And we implant the amygdala, the surgeons implant the amygdala quite commonly, and we are able to disrupt that function. So working with Ash and Parashkev, we could show that the amygdala is implicated in detecting the faces that are on the other side, and that it would orient particularly to fearful faces. And another thing happens when you stimulate the amygdala. Often people stop breathing. So we also know that seizures that involve the amygdala cause apnea, so people stop breathing when the seizure goes there. This is quite common that we see this in mesial temporal lobe epilepsy. So ictal apnea is quite common. Post-ictal central apnea, we worry about brainstem dysfunction, and I'll show you in a minute. Now, this naturally leads over to being concerned about mortality in epilepsy. Why do people stop breathing? What's important? And if you look at the charities and think about it, our clinical practice, it is really very, very humbling and very scary that there are over 1,000 epilepsy-related deaths a year in the UK, and half of them really are SUDEP. So 21 epilepsy-related deaths every week, and we must work hard to prevent this from happening. We do know that sudden unexpected death in epilepsy, which is when there's no other reason for the death found, but people having epilepsy, parallels the severity of the seizures. And we have learned from important studies that when people have big convulsive seizures, right after the seizure, there may be periods where the cardiorespiratory regulation doesn't work as well anymore. So people may initially just breathe and have a normal heartbeat, but then over the next few minutes, there might be apnea, so they stop breathing, and then finally they have cardiac arrest. And really the first thing that happens is the apnea. So working with the Center for SUDEP Research, which was an NIH-funded center without walls, we were able to augment how we investigate people with epilepsy up on our ward. We have respiratory bands. We have slightly better ways of measuring the ECG. And working with a team of another 11 centers, mainly in the US, there were many ways of understanding better what happens when we record seizures in people who are at the EMU, what happens to their breathing, what happens to their heart function, and what happens to their EEG. Here you see after a tonic-clonic seizure at the very end, complete flattening of the EEG, so post-ictal generalized EEG suppression, and they stop breathing. And we have then learned that this post-convulsive central apnea is very dangerous and likely puts people at risk. Working together with others, we've really learned that seizure types, so generalized tonic-clonic seizures, in particular the ones that have more of a decerebrate posturing, can be quite dangerous. The post-ictal central apnea, the post-convulsive cardiac arrhythmias and bradycardias can be concerning, and all this indicates brainstem dysfunction. And the post-ictal EEG suppression is what the neurophysiologist sees is basically a brain shutdown. So it was logical bringing again the imaging into play and seeing, well, the seizure happens and it involves the cortex. But from there, so many areas really talk directly to the brainstem, and so many areas of the central autonomic network are so critical and maybe dysfunctional. So we wondered, could there be structural changes in the central autonomic network? So now, almost 10 years ago, well, 10 years ago, really, we set out working with the Chalfontein and with Britta Wandschneider and Matthias Köb and others to look at what we could find if we went retrospectively and looked who died of SUDEP and find out what happened, what their brain scans looked like. And doing this, we found some important signatures of potentially SUDEP risk. We found that there were both atrophy and enlargement of certain structures. We took this a little bit further with my PhD student, Luke Allen, and with another amazing mentor of mine, Ron Harper, who is a professor of neurobiology at UCL and has taught me everything I know about autonomics. And what we found is that really the amygdala and mesial temporal structures are often enlarged in people who are of SUDEP risk or have died of SUDEP. An area that when you stimulate it causes the blood pressure to bottom out, which is just here, subcallosal, BA25, also is enlarged in the people that die of SUDEP. And then there's atrophy in other areas, in particular the thalamus, and here again in the pulvinar, the posterior and medial areas that really seem to be a setup for a SUDEP risk. We've related this to hypoxia and found out that these same areas really seem to be related to having more hypoxia when we record the seizures. So these are people prospectively followed, looked at in the EMU, and we find that they have had hypoxia during their seizures, and we find more atrophy in those. So we have major sites where you get apnea and lower blood pressure that are enlarged. We have dynamic changes also in the insula. We have areas like the cerebellum and the thalamus that are damaged. So these influences, the way these networks work together, are significantly altered. And this may be a signature of what makes the network vulnerable under certain circumstances for this tragic, catastrophic failure that leads to SUDEP. We've also looked more into the amygdala. We've looked at the volume, so the size of the amygdala. We've looked at the microstructure using advanced diffusion imaging. And looking at all these things together, we find that often the amygdala is enlarged. And the microstructure really is abnormal in a way that suggests architectural complexity of axons and dendrites is really reduced. So we also took this to the functional imaging and did a PET study here with Ben Watley when he was here from Canada, and Dr. Bomanji, who has been a huge help setting up the ICTL SPECT and is so supportive with everything we do on the telemetry unit and with our patients requiring nuclear medicine support such as FDG-PEP or the ICTL SPECT. And what we found, interestingly enough, we were expecting that things would be hypometabolic, but the greater the SUDEP risk, the more people have convulsive seizures, the more we see really that there is hypermetabolism in important deep structures in the basal ganglia, in the thalamus. So this is also quite ill understood yet, but there are clear markers. We looked at functional connectivity, again, together with Louis with his EEG fMRI program. And again, Luke did the initial studies here. And we really found that this measuring the functional connectivity using fMRI, showing the strength between two regions and the degree of temporal synchrony in brain activity, we find that there is a change in people who are at great SUDEP risk who have actually died of SUDEP. So there's a more diffuse and less organized connectivity, as you can see here. And this is currently ongoing work. You can see that we've set up a worldwide consortium, really with a few centers across the world who do EEG fMRI significantly, spanning from Montreal through Modena, Geneva, us, and Melbourne, the Florey Institute. It's been an amazing journey, also very hard going through COVID and going through all the contractual constellations that we had to master. But we are now in the process of analyzing the data, and I cannot wait to see when we actually sleep stage, what differences in networks we find between wakefulness and sleep in people who have convulsive seizures and are high SUDEP risk versus the ones who aren't. This is what we're currently working on. And another line of research that I'm really excited about is working with Rob Boix and Neela and Eugene Wong, and here our PhD students, Jan, Joanna, Sarah Gascoigne in Newcastle. We are looking at the very other end of the spectrum. EEG so far in epileptology has been mainly concerned with high frequencies. We're now looking at the very, very low frequencies. And you can see here, this is like 8:15, this is 9:15, so this is 1 hour. And you can see these massive changes with huge amplitudes. We're seeing slow activity that propagates during the seizure. This is what we're going to try to understand what this means, how it happens in different structures, how it happens in wakefulness versus sleep, and what it does in seizures, in particular in convulsive seizures during them or after them. And again here, Joanna on our side is absolutely instrumental, helping us getting our recordings absolutely pristinely. It's been quite a journey over the past 10 years working on the SUDEP side, and I've learned an immense amount from every single person I've worked with. It's really humbling. Everyone makes a contribution, and without a network of all dedicated people that I've been able to work with, we would really not be where we are. Most recently, I've also been really passionate about thinking about the increases in heat wave we're seeing, climate change, and talked to Sanjay, and being really privileged that Sanjay also thought it might be interesting to look at what happens to the neurophysiology in the brain. We obviously have intracranial recordings, and we have a telemetry unit which, by lack of power supply or adequate power supply, is not air conditioned, because once you plug something in, everything drops and there isn't enough power. So what we did is we put temperature measures in here, and we worked with weather stations and with dedicated people at UCL who understand how we can model inside-outside temperature, and we extrapolated also historic data to see how hot it was at any given point in time, and we came up with 9 people who had video EEG with intracranial electrodes in place during heat waves. And what we found is that there was a significant increase in the interictal epileptiform discharges in 3 out of those 9, and a significant increase in seizures across the group. So I'm very excited about this line of research, and I think it's really important to understand what happens during heat with the brain and how we can take this further forward. I've also been working with others, evaluating, standardizing, and improving practice, in particular with Chandor Benitsky, from the SCORE, the Standardized Computer-Based Organized Reporting of EEG, which I think is much, much needed to have a better quality of EEG reporting. Also to now taking this forward to AI, they're currently running a trial on this, and I'm privileged to be one of the readers in that trial. So I think this is really, really important to engage with this new technology. And we do an ever-improving way of testing people on the video EEG telemetry unit. And here you see some, not all members. We have an amazing nursing team, and we have an amazing physiologist team in our Sir Jules Thorne video EEG telemetry unit, which is the only really self-contained specialist video EEG unit in the UK. It's a very special place to be, and there are always more things we can do better. For example, currently we are wondering how we can best test during functional seizures, as we are recording them there. So there's always more work to do. Very dear to my heart is the work I do with the ILE SUDEP task force, and I've been privileged to work with some of the leaders in the field on coming up with a consensus statement and scoping review and SUDEP counseling, which I think is very important because to inform is to protect, and we owe it to our patients that we all communicate clearly SUDEP risk and help them understand what they can do to reduce that risk. And last but not least, I want to perhaps look a little bit in the future and the things that are currently I'm wondering about and that we are actively trying to get funding for and engaging with. I think we've come from a resection, finding the focus, into a network perspective over these past 15, 20 years. And I think it's really important that we understand networks better, that we manage to advance precision medicine for epilepsy, really, through these technologies, that we have better multimodal integration, in interdisciplinary, multi-center collaboration to address some of these important things. I think we need to improve seizure treatments. That is the main key to reduce comorbidities and mortality. And I think we've really come from resection only to understanding small lesions becoming smarter, becoming ever smarter. And I think neuromodulation is the most important next step that we need to understand and master. We're currently not there generating the outcomes we wish for, but without starting it and trying to do it better, we will not learn. So I think this is a really important area. Finally, I really want to thank all my colleagues. Here's the epilepsy team, all fantastic epileptologists. Here is our SEEG, more dedicated team, as you can see. And here is the clinical neurophysiology team. All these individuals help that we can all do our best. And I really also want to thank Mary, who is the most single amazing medical PA that I've had. And if you're looking at how she signs off, you can just about imagine what her workload is. And I sadly don't think that this is an exception, but she is doing an amazing, amazing job. On the UCL side, we have great support. In the past, Juliet Solomon was just the most dedicated person on that side. And we now have Jennifer Child, who's helping, Liam, Charlotte Burt, Jane, of course, always. So those are people who really, really help us, support us in what we do and make us better in what we do. I want to say almost final word. Hans has really shaped my experience and made me an epileptologist, set me on the track. I've learned more along the way. I was hoping that we would be able to engage with him via either video link or a short video. Now, the technical aspects of this, I think we failed to master. So I just do want to say that it's been an amazing journey. And certainly, Hans did recognize that also at the Cleveland Clinic, I was always working very hard. And he sends his very best. Now, on the professional side, people have shaped me, we've talked about them, made me the person who I am, and shaping me the most critical way. Those are my parents, and this is my mother, Beate Diehl, and my dad. And as you can see, they've both died not too long ago. They've had a very wonderful way of living their life and having a final time that was according to their wishes, and none of them had to suffer long, and I'm very, very grateful for that. And this is the now and the next generation. And this is where I try not to fail. And this is the most amazing experience I've ever had, and the most important part of my work. This is my family.
Thank you very much, Beate. I think you've showed very clearly how well-deserved this professorship is and how lucky we are to have you in our midst here at UCL. I think the inaugural lectures are usually the highlight of the academic rites of passage. And you started very early on with reminding us about your early start doing a PhD. And of course, in German medical schools, the PhDs, by and large, are kind of Mickey Mouse PhDs. They're a kind of shallow BSc project. But there are some, and Beate belongs to one of them, who make an effort to select and then do a PhD that is much more deep and is much more founded. And so you made evidence and showed that you have selected Siegfried Menze as one of your academic teachers. I know Siegfried Menze also as academic teacher because he was a professor at the alma mater in Kiel. He was the professor of physiology there. And as you could see from the picture there, he was a very strict person. This at Kiel was one of the premier physiological centers in Germany. It was headed by Robert Schmidt, who trained with Jack Eccles. Single unit recording in anesthetized cats was the order of the day. And so this kind of work Siegfried continued to do. You obviously learned very well from him. And so I reached out to him. I still have contact with Siegfried, and he told me that he remembers you well. He sends all his best wishes, and he reminded me that in his entire academic career, Beate was one of two to be awarded summa cum laude by him. So this is an accolade from Siegfried that is astonishing. And he also told me that there was a little snag that out of those two that was awarded the summa cum laude, she was the only one where there was a question of whether it was richly deserved or not. And he said that he could beat off this criticism and of the co-examiner saying that if it had been possible to give a summa cum laude with a ribbon, he would have awarded this. So in that way, I think she impressed early on in her career and made a very important contribution to the field of pain research. Now, I met Beate on an international pain meeting in 1988 in Erlangen. I remember this meeting, amongst many other things, was that it was snowing very heavily. There was chaos of travel. I nearly didn't manage to come to Erlangen. And when I looked out of the window this morning, I thought, oh my God, this is going to be a rerun here. These few snowflakes make London like heavy snow in Erlangen in Bavaria look like, and everything will almost shut down. But obviously it didn't. We enjoyed a fantastic lecture and an overview about amazing research that you have provided. Now, we also go back then in Germany for other events. So we tried in the 90s to recruit you, as you know, as into the neurology department in Würzburg where I worked. And to our big chagrin, she declined. Obviously, you could see that she had much better options, much better things to do. And it's much better for the field of epilepsy that she chose that way, to train in the United States and then have this incredible productive period of work to do. I also think that I was very lucky to be then able to recruit her. So second time lucky in a way to bring her back to Queen Square. And I think it has been an incredible pleasure to see how you flourish here, how you have made your mark, how you have contributed incredibly on an academic level, but also clinically. Now, The German passage, the rites of passage in academia, involves not only a PhD and then a professorship, but there's a very important step in between, and you have missed out of that. This is called the Habilitation. It is a process of regaining the venia legendi, the right to lecture, to teach at a university. And of course, as my uncle, he is professor of German literature, reminded me, is that if you have a summa cum laude, you can actually skip this step, and he did so. So in some way, it is right that you skip this step and didn't have to do that. Because it's actually quite interesting for those of you who don't know that, what you do when you have to do a habilitation. Now, first of all, you have to do a body of research and academical leadership and productivity and serve in the university, and you have richly done that. There is no doubt about it. This has been much more than the average German habilitation procedure. What you then also have to do, of course, is that once you have put this document together, that you have to go and visit every person, the chairs in the faculty. So in a big medical faculty, you spend half a year to a year to go around, shake hands. Some people invite you for a nice chat, for tea, coffee, and so forth. Some is more, as I can tell you, an examination type of meeting. One of my colleagues, Ralph Baron, said what they really want is to increase your laundry bill. You have to go and sweat through 5 suits before you'll get your habilitation. And it all accumulates that you then have to give a talk in front of the faculty without slides, and there will be a vote on whether you pass or not. I'm sure you would have excelled in this. I have no doubt about that. But it also reminded me a little bit in the run-up of the preparation for this inaugural lecture that there's one thing that the talk is about. First of all, you're not about to talk about your own work. So it has to be something different. And you have to submit 2 topics. And you will be told on the day in the morning which topic you have to talk in front of the faculty. So it's a little bit, when I knew that Lei was in Amsterdam and I saw the snow, and also before whether we had other people perhaps speaking. So I was, after my habilitation, a little bit prepared to talk about something that I was only told in the morning what to do. So in that way, I think I think you would have passed very well in a German habilitation system, and certainly everybody would be proud in the German university to have you as a professor, as we are. So there are 3 things that I want to say. The first thing is, of course, on behalf of our university, to make clear that we appreciate your scholarship, your leadership in developing new techniques and exciting new research, and this has been very well reviewed, what you showed us here. So we have now 3 professors related to clinical neurophysiology at our alma mater. This is about 50% of the entire country that is in this university. Of course, I also want to express my thanks on behalf of our university hospital, UCLH. You have made a big impact. This has introduction of new techniques, patient care, training of the next generation of people who contribute to the care in the country and further afield about in epilepsy. And you have made it very clear how important it is that the topics that you're dealing with, SUDEP, epilepsy, is an area where we can make, and your work has done so, an amazing progress and impact on the well-being of our patients that are under our care. And last but not least, I want to give my personal thanks to you for being a very reliable, dependable colleague, very principled, with a certain high amount of integrity, and I very much appreciate our personal friendship. Thank you very much, Beate.